I see Fiona Braca online. Fiona Braca, I don't know if you can hear us. We would like to test your video and audio systems, if that's okay. Bonjour, Dr. Fiona Braca. We are just trying to test your audio and your video settings, if you can hear me. Meenakshi, how are you? I hope it's all good. You're a co-host.
Hi, Marta. Doing well. How are you?
All good, all good. Dr. Fiona, if you can hear me. Oh, wait, sorry. No, the other way around. Okay. So we are trying to test your audio and video settings, if you can hear me. Where is she? Okay. Bonjour, Dr. Dango. Thanks for joining us. Nice background. All good.
Hello,
Would you
Martha.
mind?
Good morning.
Okay, perfect. I think I can hear you. Would you mind speaking up a bit? 1, 2, 3, 4, 5. Again. I think it was okay without the headset. But let's see.
Good morning. Can you hear me?
Come again, sorry.
Good morning. Can you hear me?
Yes, perfect. That's okay. Thank you so much.
Good.
Let's see.
Hi, Otto.
He's here as well.
I can see his head.
Hello, morning.
Dr. Fiona Braca, if you're online, we are trying to test your video and audio settings as well. I don't know if you can hear me.
Yes, I can hear you. Sorry, how's
all good, all good. Awesome. Okay, it was fine without that many. Like, there's a lot of space above your head, so if you can put it down a bit, the camera, I would. Yes, not that much, because then we can see the bed. And we don't.
I know.
Exactly. Okay, can you talk a bit
Okay, testing, 1, 2. Can
Yeah.
you hear me?
Thank you so much. Loud and
Okay.
clear. Thanks.
All right.
Hello? Hello?
Hi, Fiona. Good to see you online. How are you? We would like, so Fiona at the web, just to clarify, because we have tested Dr. Braca. So Fiona, if you wouldn't mind, put your video on and your audio settings as well. Voila.
Hi, Marta.
1 second. Okay, I can see you now. Can you speak for a bit?
Hi, Marta. I hope you can hear me.
Yes, all good. Thank you so much.
Thank you.
Elizabeth, can we test you now?
1, 2, 3, 1, 2, 3. 1, 2, 3, 1, 2, 3. 1, 2, 3, 1, 2, 3. Test son. 1, 2, 3, 1, 2, 3. Test son. Test son. Test son. 1, 2, 3. 1, 2, 3. Closer. Closer. 1, 2, 3. Test son. 1, 2, 3. 1, 2, 3. Test son. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. Closer. 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 1, 2, 3. 1, 2, 3. 1, 2, 3. Ça, c'est bien? OK. Un, deux, trois. C'est mieux là, non? OK. Voilà. Ah, je dois baisser un peu parce que là, je vois dans. Je me suis. Oui, parce que quand c'est trop bas aussi, c'est pas. Là, je suis bien.
Hello. Hello, 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 1, 2, 1, 2, test. Hello, 1, 2, test. Hello, 1, 2, test. Hello, 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 hello. Hello, 1, 2, hello, 1, 2, test. Hello, 1, 2, so 1, 2, 3, 1, 2, 3. Hello, 1, 2, hello, 1, 2, test. Hello, 1, 2, test. Hello, 1, 2, test. Hello. Hello.
Yeah, you want me to say something? Okay. Can you hear that? All right.
Hello, 1, 2, test. Hello, 1, 2, test. Hello, 1, 2.
Test, test. Test. Test, test.
The journalists, just say that we will be about 5.
Bonjour, mesdames et messieurs de la presse. Nous allons démarrer cette conférence dans 5 minutes. Nous attendons encore l'arrivée de Son Excellence, Monsieur le ministre de la Santé. Ladies and gentlemen of the press, we will start this press conference in 5 minutes. We're still waiting for the Honorable Minister to join us. Thank you.
D'accord, nous attendons. Merci.
One, two, three.
Bonjour, good morning. I'm Elizabeth Kwaovi. Welcome to the WHO Africa media briefing, which is taking place at the 72nd session of the World Health Organization Regional Committee for Africa in Lomé, Togo. Bonjour, je m'appelle Elisabeth Kwaovi. Bienvenue à cette conférence de presse de l'OMS Afrique qui se tient à l'occasion de la 72e session du comité régional de l'OMS pour l'Afrique, ici même à Lomé, au Togo. This is a hybrid press conference where we have journalists in the room with us, as well as others joining from all over parts of Africa. Il s'agit d'une conférence de presse hybride. Certains journalistes sont ici présents dans cette salle, tandis que d'autres vont se joindre à nous en virtuel. First of all, some housekeeping. For those of you joining online, you can choose the language you would like to hear for the press conference by turning to the globe on the bottom right of your screen and select your language. Quelques annonces d'intendance. Pour ceux qui sont en ligne, prière de choisir la langue que vous souhaitez écouter en sélectionnant le globe sur le coin droit, en bas droit de votre écran et en sélectionnant la langue de votre choix. For everyone in the room, both participants and journalists, please only activate your microphone when you are ready to speak and when you are called upon to ask a question. This is because if more than one microphone is on, this will freeze the system, the audio system, and it will not work very well. Pour tous ceux qui sont dans la salle, prière d'allumer votre micro que lorsque nous vous donnerons la parole. Parce que lorsque plusieurs micros sont allumés en même temps, cela bloque le système. Now, joining us now is Dr. Matshidiso Moeti, WHO Regional Director for Africa. Dr. Moeti, over to you to introduce the other panelists. Thank you.
Thank you, Elizabeth. And good day, bonjour, bon dia, and welcome to all the journalists who are here in Lomé and those who are joining us online. During today's press conference, we'll focus on the highlights of the 72nd session of the WHO Regional Committee for Africa. This is Africa's top annual gathering where the continent's health agenda is set. I'm very pleased to be joined today by the esteemed Minister of Health of Togo, my good friend and brother, Professor Moustafa Mijyawa, who is the chair of the 72nd Regional Committee, and by my sister, the Honorable Minister of Health of Uganda, Dr. Jane Ruth Acheng, who is also the second vice chair of the RC72. A warm welcome to both of you, and thank you for making yourselves available for this press conference, despite what has been a very demanding week. I'd like to begin by conveying my sincere thanks to President Faure Gnassingbé, to Professor Moustafa, and to all the people of Togo for being such generous hosts this week. The 72nd Regional Conference, attended by about 30 health ministers from the African region, with others joining online, has provided a critical platform to discuss some of the most pressing health issues impacting our continent. This is the first time since the onset of COVID-19 that we've been able to meet in person. But the hybrid component reminds us that our lives and our ways of working have been irrevocably impacted by the pandemic. Indeed, the pandemic has been a wake-up call for the African region of the need to build resilient health systems that have the capacity to deliver quality, uninterrupted routine healthcare to our people while coping with health emergencies. We spent the past week taking stock and interrogating our priorities while identifying actionable ways in which to make our continent healthier. One of the primary outcomes was the adoption by African health ministers of a new 8-year strategy to transform health security and emergency response in the region. The result of extensive consultations with both African health ministries and a range of other institutions, the Regional Strategy for Health Security and Emergencies 2022 to 2030 commits member states to reaching 12 critical targets by 2030 to strengthen their capacity to prepare, detect, and respond to health emergencies. Among these, 80% of African region countries should have secured predictable and sustainable health security financing and have established health districts with functional service delivery and quality improvement programs. Meanwhile, 90% or 9 out of 10 should have the capacity to mobilize an effective response to health emergencies within 24 hours of detection. To realize these goals, member states have agreed to commit the necessary political will to provide the requisite technical leadership while mobilizing adequate human and logistical resources. WHO will support countries to operationalize the new strategy through a recently launched flagship initiative currently being rolled out in 5 countries. There are plans to expand that number significantly before the end of the year, with programs to be scaled up regionally over the next 5 years. So while our region experiences the highest number of health emergencies globally, there are also many other pressing health problems. Africa is grappling with an increasingly heavy burden of chronic diseases like diabetes, the severe forms of which are costing precious lives that could be saved with early diagnosis and care. On Tuesday, the health ministers adopted the strategy known as PEN+, a regional strategy to address severe non-communicable diseases at first-level referral health facilities. On a continent where severe NCDs are mostly treated at tertiary hospitals, which are mainly in cities, this strategy to boost district-level capacity for early diagnosis and management of severe NCDs is a major step towards health equity, bringing care to rural communities. I'm also extremely pleased to share the news about the launch of a new campaign by African health ministers supported by WHO and partners to curb sickle cell disease. This is one of the most common yet least recognized illnesses in the region. Like childhood TB, for instance, it's been pushed to the sidelines for too long. For sickle cell disease, most African countries don't have the resources to provide comprehensive care to patients. This, despite the availability of proven, cost-effective interventions to prevent, diagnose early, and manage this condition. As we've seen with COVID-19, the impact of sickle cell disease extends well beyond health, posing significant economic and social costs for patients and their families. We can't afford to continue ignoring the threat, so greater investments and stronger collaboration and partnerships need to be prioritized. Childhood TB also doesn't typically receive much attention, even though 1 in every 3 TB cases among children globally occurs in our region. So highlighting this fact in the minds of policymakers is imperative to ensure timely diagnosis and treatment. We've learned from monkeypox that we cannot afford to ignore diseases common in Africa until they make headlines elsewhere. So while there are considerably fewer confirmed cases of this disease in Africa compared to other regions, we must not relax. There's a need to scale up the response and readiness capacity to ensure optimal detection of cases. As WHO, we reiterate our appeal to countries to focus their response efforts on raising awareness, surveillance, infection prevention and control, and supportive management of positive cases. This is extremely important considering that no monkeypox vaccines or antivirals are yet available in African countries. We've had 406 confirmed cases and 7 deaths across 11 African countries with the Democratic Republic of the Congo and Nigeria continuing to account for most, about 80% of cases. So we're currently mapping availability of existing monkeypox vaccine supplies and planned production, assessing needs, and our headquarters colleagues are making an appeal for these to become available in the region. In the DRC, WHO teams are on the ground in Beni, in North Kivu, supporting the country's office to vaccinate those at high risk of Ebola virus disease. And an initial 200 doses have been made available, arrived in Beni, and we believe the vaccination campaign started this morning. The health authorities declared a resurgence of Ebola this Monday following the confirmation of the case in Beni, and analysis has showed that this case is genetically linked to the 2018-2020 outbreak of Ebola in that country. So finally, for COVID-19, many countries are making impressive progress towards higher coverage rates among priority groups, especially health workers and people older than 50 years who are at higher risk of severe illness and death. But there is still a lot to be done, and I need to stress that the COVID-19 threat is far from over. As WHO, we continue to push for service delivery strategies that focus on high priority groups in countries where fewer than 30% of the population is vaccinated. We firmly believe it's possible for African countries to catch up with the rest of the world if we take vaccination services to the people through mobile and outreach teams and the establishment of dedicated vaccination teams. So to end, I'd like to thank you all very much for joining us. Merci, Monsieur le Ministre, d'être avec nous. Thank you, Madam Minister, for having joined us. And I look forward very much to, I'm sure, what will be a very interesting discussion. Thank you.
Thank you very much, Dr. Moeti. Professeur Moustafa Mijyawa, est-ce que vous pouvez nous parler de l'expérience du Togo pour les mesures qui ont été prises afin d'améliorer la préparation aux situations d'urgence?
Merci, Madame la directrice régionale, ma chère collègue ministre de la Santé de l'Ouganda, Madame la modératrice, Madame la représentante de l'OMS au Togo, chers amis de la presse et de la communication, merci d'être là pour échanger avec nous pour ce qui a été fait durant tout ce sommet de la santé en Afrique. Et la question qui a été posée a trait aux dispositions que nous prenons pour faire face aux problèmes d'urgence. Nous avons tiré les leçons de ce qui a été fait, par exemple pendant la COVID-19, et tout le monde ici est au courant des dispositions qui ont été prises par le chef de l'État, la mise en place d'organes, le renforcement du système de santé, les équipements des centres de santé, et en dehors de ça, bien évidemment, tout ce qui est du matériel relevant de la lutte contre la COVID-19, que ce soit le matériel de protection ou la vaccination, où aujourd'hui nous avoisinons les 40% de la population cible en termes de couverture vaccinale. Alors, ce qui a été tiré comme enseignement, d'abord, c'est que la collaboration entre les différents ministères a été renforcée parce qu'une épidémie, une urgence fait appel à tous les départements ministériels et donc il y a nécessité d'une cohésion gouvernementale, une cohésion intersectorielle pour mener à bon escient la lutte. Vous vous souvenez de tout ce qui a été pris comme disposition dans ce sens. De la même façon, c'est toujours arrimer nos actions, arrimer les actions du gouvernement avec les actions des partenaires. Et c'est dans ce sens d'ailleurs que, tirant les leçons encore une fois de ce qui s'est passé, il y a un programme dont parlait tout à l'heure la directrice régionale qui consiste à se dire, bon, qu'est-ce que nous devons faire, mettre en place pour qu'une fois enclenché, en tout cas, une fois survenue une quelconque épidémie, tout le processus soit d'emblée enclenché, que ce soit en matière de logistique, que ce soit en matière de ressources humaines. C'est ce qui fait que dans le cadre du programme dont il s'est question, le programme qu'on a appelé le programme Surge, dont le Togo fait partie des 5 pays pilotes de l'Afrique. Dans le cadre de ce programme, il y a une 50aine d'agents qui ont été formés. Il y a du matériel qui a été mis à disposition. Il y a quelques jours, on a réceptionné ce matériel devant les locaux du ministère de la Santé. Et il y a toujours, bien sûr, la nécessité d'une bonne coordination avec un volet aussi important qu'il ne faut pas oublier, qu'il ne faut pas omettre. Nous avons vu ça à travers la COVID-19, le volet communication. Et encore une fois, nous vous disons merci de nous avoir aidés dans ce processus-là pour transmettre la bonne information à la population, que ce soit en termes de mesures que l'on a prises ou en termes des dispositions à prendre. Vous vous souvenez également que dans le cadre de la lutte contre la pandémie, je veux parler de la COVID-19, il y a un certain nombre de dispositions qui avaient été prises par le chef de l'État pour alléger les conséquences économiques de la pandémie, notamment à l'égard des populations les plus vulnérables. Bon, voilà donc schématiquement ce qui a été fait et ce qui a été mis en place et ce qui a été repensé et mis en place pour que demain, la riposte soit beaucoup plus prompte et beaucoup plus efficace.
Merci infiniment, professeur Mijyawa. Honorable Dr. Aseng, what lessons has Uganda learned from the COVID-19 pandemic?
Thank you very much for the question. Allow me, first of all, to thank the regional director for organizing this press briefing, and my brother, the Minister for Togo, for hosting us here in Togo, and for a very well organized 72nd Regional Committee. The world will be aware that Uganda has battled many pandemics before, and Uganda is one of the countries that I would say was relatively prepared to handle the COVID pandemic. But as many of you are aware, the COVID pandemic overwhelmed the world, and there is no country that can say they were prepared in terms of capacity to handle the pandemic. However, unlike many countries, Uganda had only 3 waves, and the most vicious wave was the Delta wave that overwhelmed our capacity in terms of surveillance because it was widespread throughout the country, in terms of human resources, in terms of commodities, in terms of supply chain, but also in terms of financial resources to handle the pandemic. To date, Uganda has lost 3,580 people from the pandemic and treated over 1,680,000 people. We currently have only 3 people on admission. And why is that? This is because of the multi-sector approach to handling the pandemic through a national task force that was set up by His Excellency, the President of the Republic of Uganda, who has always been a champion in handling pandemics. Our multi-sector approach enabled all sectors of government, including partners, to participate in handling the pandemic. In addition, our robust way of approaching the communities and making them understand that the pandemic starts with them and ends with them. And so their participation and ownership of the pandemic was paramount to the response, and it would determine whichever direction that the pandemic went. But I also must appreciate our partners in a big way. WHO, the Global Fund, and many other partners who came in a timely manner to provide the much needed resources. Many of you will recall that at the start of the pandemic, Africa was nearly neglected by the international community in terms of commodities, in terms of basic necessities. And this prompted Africa to become very innovative. No wonder the pandemic did not devastate Africa like many other nations. To date, Africa has a capacity, just like Uganda has a capacity. However, there is still need to enhance that capacity by ensuring that our primary health care facilities are well equipped. In other words, we need to start thinking about universal health coverage that is accessible to everyone if we are to ensure a resilient system. Because handling the pandemics is not a centralized thing or at a national level. Handling the pandemic begins from the communities. So ensuring a robust system right from the community level to the national level is what we need. In Uganda, our preparedness and detection mechanism had long been built because we have laboratories all over the country that can detect any pathogen of epidemic potential. So this enabled us to be able to detect COVID from wherever it was and to handle it accordingly. The strength that we need to build now lies with human resource. We need a surge capacity that can be deployed anytime, anywhere. We do have this, but it needs to be enhanced. We are also strengthening our supply chain system so that it can reach up to the grassroots. It is strong enough to reach every facility and every district, but we want it to reach up to the grassroots people. And lastly, we are emphasizing on a multi-sector approach and integration into the routine system because COVID disrupted essential services. And it is not only in Uganda. Many of the routine services that people were supposed to access were interrupted. And that needs to be addressed head on now so that we don't see the gains that we have made over the years in handling communicable diseases like AIDS, TB, and malaria, the gains that we had made in reversing neglected tropical diseases, the gains that we had started putting in place in handling non-communicable diseases reversed. There is need to think widely about some of these diseases because the impact may be much bigger than what we have seen with COVID-19. However, the beauty with COVID-19 is that it helped many African countries to build stronger systems because the intensive care units that we did not have, we now have. The oxygen supplies that were lacking are now down up to primary health care level. The medicines that were not available are now available, and many more human resources have been trained. So we need to use this platform to enhance it so that we can have universal health coverage. I thank you.
Thank you very much, Honorable Minister. Now that we have heard of all our panelists, journalists, it's now your turn to ask questions. To do so, please use the Q&A function on the Zoom application. Please remember to give your name and the news organization that you represent so that your question can be asked. Pour ceux qui sont présents dans la salle, veuillez lever la main pour qu'on puisse vous donner la parole afin de poser votre question. We also have on hand Dr. Fiona Baraka, Team Lead for Emergency Responses, Dr. Tierno Balde, Regional COVID-19 Incident Manager, Professor Jean-Marie Dangou, Coordinator for Non-Communicable Diseases Management Program, and Dr. Fiona Atuhebwe, new vaccines officer at WHO Africa. So we're going to turn now to the questions from the media. The first question is from Paul Adepoju with the Lancet, and it is a question to Dr. Moeti. Dr. Moeti, since the declaration of monkeypox as a public health emergency of international concern, what impact has this declaration had on response in Africa? And then I will turn also to Togo and Uganda for the same question. And this is considering the fact that monkeypox vaccines are still not available on the continent. Dr. Moeti.
Okay, thank you very much indeed. I think first of all, just to say that the work to support African countries which had cases of monkeypox, several of whom were countries where this is endemic, but a couple of whom were seeing this for the first time, countries like Ghana, actually started before this declaration was made by the expert group. So we were already on hand seeing that something slightly unusual was happening in other countries, something very unusual was happening in mainly Western countries, and that there was a need to make sure that in our countries as well, that the level of awareness, readiness, and where needed, where there were cases, response was being sharpened. So I think since the declaration, what has happened is that the level of awareness among ministers of health, health leaders, and partners, even in countries in Africa where the monkeypox is not endemic, has been increased. We have had additional resources allocated to us in the region that have enabled us to intensify our support to our member states so that they sharpen what they are doing. I mean, I think what we can say is that we have worked and finally been able to obtain some tests, supplies, and have distributed these among our countries to enable more rapid testing and confirmation of cases of monkeypox that will enable the diagnosis and the action to take place faster. We've engaged very intensely in public education on monkeypox, working with ministries of health, clarified what it is that needs to be done, even in the absence of a vaccine, so that we minimize transmission from cases to other people. And there's been work by our teams at the central level in the affected countries, going to the peripheral level to make sure that people are aware that if there is somebody who is seeming to be a suspected case, what you avoid if you are the colleagues, family, people around that person, to minimize transmission between yourselves. We've been able to distribute some resources to the affected countries for local action so that they can bring on board the technical expertise they need and the capacity to take these actions. One thing that has not become available yet is vaccine in African countries. We are working through our headquarters to try to seek supplies of vaccines so that these may be available as we start to see new cases in countries and we can have the experience of using this vaccine in Africa. There has, of course, been a very intensive global epidemic taking place, mainly among men who have sex with men in Western countries, and that's where the concentration on vaccine supplies has been. But we are making a plea that the situation that African countries have experienced with COVID-19 vaccines should not be repeated. And we are still hopeful that with the advocacy being carried out and the discussions with countries that are helping to produce the vaccines, that we may obtain vaccine supplies for African countries. This is not the case up to today. So I hope with that I've responded to both of the questions that were posed.
Thank you very much, Dr. Moeti. Dr. Hassan, what was the impact of this declaration for Uganda?
First of all, allow me to appreciate the World Health Organization for declaring the monkeypox a public health emergency. However, for us as Africa, and I say as Africa because I'm an African, We have had monkeypox in some countries in Africa for many years. And we wondered why it became a public health emergency when we have had it before. But not to say it is not an important undertaking that we need to look into. We already have infrastructure that was set up for COVID-19. So what we only needed to do was to reactivate the same infrastructure to manage the monkeypox pandemic. So to date, we have sensitized our entire population about the monkeypox and how to identify the signs and symptoms and report. We have built capacity in 3 laboratories in the country to test for monkeypox. And to date, we have analyzed over 100 samples that have all turned out to be negative. So Uganda does not have any case of monkeypox. We have a strong surveillance system that runs throughout the country. Both health workers in conjunction with the communities that are alert on the lookout for any case that may come up. We have a strategic committee that is made up of partners and various partners, WHO, CDC, UNICEF, and many others who sit on this committee so that we can plan together on any response that we need to undertake. So we are open to any guidance that will come from WHO, but we are also working hard to ensure that we do not have a case of monkeypox in the country. I thank you.
Thank you very much. Professeur Mijyawa, quel est l'impact de cette déclaration sur le Togo?
Merci, madame. Lorsque nous avons appris que l'Ouganda a observé des premiers cas, nous avons d'abord cherché à vérifier la source de l'information. Lorsque nous avons eu l'information officielle, la première chose que nous avons faite, c'était d'élaborer un communiqué à l'égard de la population pour porter l'information en disant, bon, voilà, cette maladie, des cas ont été observés au Ghana. Cette maladie, voilà comment elle se traduit de façon, dans des termes simples. Et surtout, voilà les dispositions d'hygiène à prendre. Donc, le communiqué est passé. Et comme en Ouganda, ce que nous avons fait ici, c'est de réactiver tout le système qui est déjà mis en place dans le cadre de la COVID. Et c'est ce qui fait qu'une formation a été faite au CHR Lomé Commune en lien avec cette maladie pour dire de quoi il s'agit et en même temps donner l'information exacte à la population par des spécialistes qui l'ont fait. Et au niveau de l'Institut national d'hygiène, c'était de savoir et de mettre en place l'acquisition de kits pour le diagnostic et en lien avec nos partenaires, au premier rang desquels figure l'Organisation mondiale de la santé que je salue et dont je salue d'ailleurs la représentante au Togo qui nous appuie énormément et qui est tout le temps avec nous, en lien donc avec les partenaires, que ce soit l'OMS, l'OAS, l'Organisation ouest-africaine de la santé, le CDC Afrique, nous conjuguons nos efforts pour que nous puissions y faire face. Donc, compte tenu du fait qu'on avait déjà un soubassement de lutte contre les pandémies en place via la COVID, ce système a été davantage réactivé et galvanisé. Et bien évidemment, l'unité de prise en charge d'éventuels cas mise en place au CHR Lomé Commune a été réactivée. Donc, à peu près, voilà comment ça s'est passé au Togo et nous continuons bien évidemment à être en étroite collaboration avec les partenaires et avec tous les pays puisque on sait qu'une maladie comme celle-là n'a pas de frontières.
Merci infiniment, Monsieur le Ministre.
If I may add something?
Yes, sure, Dr. Moeti.
Yes. Thank you very much. I'd just like to add something following the Minister's comment that Africa had been familiar with this disease, and it's the first time that we've had it declared public health emergency. I mean, I think the experience that we've seen, it's been unique, the speed of spread, both in terms of the increase in numbers of cases and the geographic spread of this disease in a number of countries. It spread from Europe and has gone to several continents very quickly indeed. That's what caused the alarm. And there was some concern that we might start to see human to animal transmission, in which case then even the speed will be propagated even more. I do think, however, in agreeing with the minister, that we need to learn from this experience, and we need to see how to continue to push and promote an equitable approach across different parts of the world, so that, you know, we have a continent where this spreads much more slowly, the number of cases is not very large, the rate of deaths is certainly higher, but this is happening in countries that are dealing with many, many other outbreaks and pandemics. And if the tools can become available to enable us to contain this in African countries, then the governments can do other things with the capacities that are being devoted now to COVID-19. So for us, this is an issue. We know many of our countries are dealing with COVID-19, but we're dealing with many other outbreaks at the same time: cholera, measles, Marburg. So if there's anything that's available that can enable countries to control, move on, do something else, that for us is a good motivation now that vaccines are becoming available at the global level. Thank you.
Thank you, Dr. Moeti. I believe we have a question from in the room. It's Pyramid FM. Pyramid FM.
Yes. Alors, bonjour, Monsieur le ministre de la Santé du Togo. Bonjour, Madame la directrice de l'OMS Afrique. Et ma question s'adresse à Monsieur le ministre. C'est concernant la nouvelle campagne sur la drépanocytose qui est annoncée. Nous savons que la drépanocytose est une maladie héréditaire qui peut être évitée quand les partenaires connaissent leur test ou leur statut. Et aujourd'hui, le test de l'hémoglobine, ou qui permet de savoir si les deux partenaires peuvent avoir d'enfants, aujourd'hui, ce test est toujours payant et beaucoup de personnes n'arrivent pas à le faire. Est-ce que le Togo pense aujourd'hui d'abord rendre gratuit ce test et également avoir une loi qui oblige les deux partenaires à savoir le statut avant le mariage? Et également, quelle sera la place qui sera accordée donc à la sensibilisation, à la prévention, surtout dans les communautés reculées? Voilà ma question.
Merci à la journaliste qui a posé la question relative à la drépanocytose. Et en fait, la question rejoint ce qu'on appelle le bilan prénuptial. C'est-à-dire, avant mariage, il y a un certain nombre d'examens que l'on fait. Et il faudra maintenant rendre systématique, parce que c'est ce qu'elle est en train de dire, voire obligatoire l'électrophorèse de l'hémoglobine. Et donc, l'idée, c'est la question en filigrane, c'est l'accessibilité. Et tout ceci, en réalité, va faire partie du paquet de la couverture maladie universelle. En fait, ça rejoint à peu près cette question-là. Et vous savez très bien les efforts qui sont en train d'être faits. Et il est tout à fait cohérent d'imaginer que l'électrophorèse de l'hémoglobine, tout comme le groupage par exemple, soit intégré dans le paquet du bilan prénuptial. Et bien évidemment, dès l'instant où on dit couverture maladie universelle, accessibilité, trouver le mécanisme pour que ça soit à un taux totalement accessible et que ça soit intégré dans le paquet. Et en fait, cette question et bien d'autres font partie de ce qu'on est en train d'envisager dans le paquet que nous prévoyons dans le cadre de l'assurance maladie universelle. Voilà ce que je peux dire à ce stade où nous sommes.
Merci infiniment, Monsieur le ministre.
En sachant que
oui,
il faudra aussi que, à travers l'éducation, à travers l'information, que les gens comprennent que lorsqu'on a le résultat de l'électrophorèse de l'hémoglobine, quand on est AS et que sa conjointe est AC, bon, voilà les risques quand même d'avoir un SC parmi les enfants. Ce n'est pas un risque de 100%, mais c'est un risque quand même qui existe. Bien informer les gens, bien les sensibiliser, ça fera partie également du paquet. Parce qu'il peut arriver aussi que des gens soient AS d'un côté, AC ou AS de l'autre, et qu'ils vous disent, mais malgré tout, nous voulons être ensemble. Donc ça, c'est le travail de l'éducation et de la sensibilisation. Merci.
Merci à vous, Monsieur le Ministre. I have a set of questions from the British Medical Journal. The first one is to Dr. Moeti. Dr. Moeti, what is the WHO's level of concern for the Ebola outbreak?
Yes, thank you for that question. I think you are referring to the new case of Ebola in Beni in the Democratic Republic of the Congo, where one person has been confirmed to have had Ebola who died. I mean, of course, we're always concerned when there is a case of Ebola, because we've had experience where that probably means that other people are infected and there is need to swing immediately into action to do something about it. We, however, know that in this part of the Democratic Republic of the Congo, there's been quite a lot of experience. There has been experience recently of bringing under control Ebola, and a lot of work has been done to build up the capacity at the local level in that province to respond immediately to an outbreak of Ebola. So we recognize as well that this person is somebody who is connected to the outbreak that happened between 2018 and 2020. So there is also the issue of survivors of Ebola and the need to reinforce the follow-up and ensuring that then it's easy to recognize once among them a case is researched and that the Ebola outbreak is starting again. I believe that, of course, WHO will, and our team has already taken action to get to that province to reinforce the capacity to respond to that outbreak. But I'm very optimistic that after these recurrent outbreaks of Ebola, and particularly the last prolonged outbreak, and all the investment that was made in building the system, so at the level of primary care, ensuring that the surveillance is there, and the fact that it's been possible to obtain supplies of vaccine and start a vaccination campaign around this case so quickly, it should be possible to contain this outbreak relatively quickly. We will remain alert, we'll remain ready to deploy more capacity, we'll remain ready to mobilize the resources the government may need, but we are really noting that the capacity in that place has now been reinforced, and we'll rely on the government to take the lead and will support as WHO as is needed. Thank you.
Thank you very much, Dr. Moeti. Now I have a series of follow-up questions. So the first one to Dr. Braka online. Dr. Braka, is it true that UN peacekeepers could be withdrawing from affected regions following protests, and could their withdrawal hinder efforts to contain the Ebola outbreak? Please, Dr. Braka.
Thank you very much, and good morning to all journalists and panelists. We are aware of some concerns, security concerns in North Kivu. And of course, this we have to consider when we are responding to the outbreak, because the aim is to quickly interrupt the transmission of the virus. During past Ebola outbreaks, WHO has worked closely with health authorities in such situations. And at the moment, WHO is already on the ground in Beni working to trace contacts, to raise awareness about the disease, and to support the vaccination activities that have actually started today. In situations where access is a problem and there is a challenge with the response, WHO usually collaborates with the local health authorities and the community leaders to provide the healthcare to the beneficiaries. So there is some collaboration to ensure that there is humanitarian access to allow for health responders to deliver important health services to curb the spread of the virus.
Thank you, Dr. Braka. There is another question, a follow-up question. The strain that has been detected is the same as the one detected in 2018-2020. Does this mean that people should have existing immunity against Ebola and they should have strong protection against Ebola? What is your opinion on that?
It is an important question. As the regional director indicated, the new case is genetically linked to the 2018-2020 outbreak that happened in North Kivu province. The initial laboratory findings indicates that this case likely represents a new flare-up of that outbreak that occurred in 2018 and is possibly initiated by transmission of the virus from a persistently infected survivor or a survivor who experienced a relapse. However, the detailed investigations that are currently ongoing will be able to give us more indication about the source. It's also important to note that the vast majority of survivors do actually clear the virus and recover within 6 months, but a small proportion may end up potentially carrying the virus and may be able to transmit it in particular circumstances. But also equally important is that follow-up of these survivors is key, and we all have to support and make sure we don't allow stigmatization, but really provide that support that they need, because they do not represent a threat to communities or their families. We have thousands of people that have survived and their lives are back to normal. But in terms of immunity, we have a very highly effective vaccine, over 94% efficacy. And the challenge is that the studies so far have not been able to show how long vaccine-derived immunity lasts. And so that's why we recommend that revaccination be done for those that are targeted if they have not received the vaccine in the last 6 months preceding the outbreak. And it is a ring vaccination approach that will target contacts of contacts, and health workers. We are really pleased to see the speed with which the response has gone, and that the vaccination has actually started today in Beni, initially targeting health workers.
Thank you very much, Dr. Braka. We now have a question from the room. Je crois comprendre que VOA Afrique a eu des questions à poser. Vous avez la parole.
Merci beaucoup. Je suis Faustin Moussou, VOA Afrique. Alors, je voulais m'intéresser au retour de la maladie, enfin, du virus de poliomyélite. Au-delà de la vaccination, l'autre fois dans la salle, nous avons écouté le représentant du Niger qui évoquait la lassitude des populations à propos des vaccinations répétitives et surtout qu'on leur avait dit que le continent ou les pays ont vaincu la maladie. Aujourd'hui, comme ça revient, je ne sais pas, quelles sont les actions que vous prévoyez? Merci beaucoup.
À qui s'adresse votre question?
Bon, peut-être comme nous sommes sur le continent, à Madame la directrice régionale. Bon,
Merci pour la question relative à la poliomyélite. C'est vrai qu'il y a quelques années, à travers la vaccination, nous avons pensé que la question de la polio, la page était définitivement tournée. Et il y a eu donc même une certification de l'OMS concernant le continent et donc le Togo, disant que la maladie est éliminée. Alors, compte tenu du fait que c'est quand même une maladie qui peut avoir non seulement un fort taux de mortalité, mais qui est source de paralysie. En pareil cas, dès l'instant même où on dit que c'est fini, il y a une sorte de suivi que l'on fait. Et le suivi a montré qu'il y a quelques cas que l'on observe. Alors, il vaut mieux être trop prudent que pas assez. C'est ce qui a fait que d'emblée, on a dit, bon, mais tous les enfants qui ont entre 0 et 59 ans doivent être vaccinés par le vaccin oral. Et c'est ce qui nous a conduit il y a quelques jours à lancer cette vaccination au Togo. Et aujourd'hui, on a vacciné à peu près 1 700 000 personnes. Ça, c'est le premier tour. Le deuxième tour étant prévu pour 4 semaines plus tard. Et donc, c'est dans cette situation-là que nous sommes. Et cette disposition a été prise par les autorités togolaises, bien évidemment, conformément aux recommandations de l'Organisation mondiale de la santé. C'est vrai qu'il y a nécessité de sensibiliser, en tout cas de davantage solliciter les populations, c'est vrai, d'autant plus qu'on a constaté que la COVID avait pris beaucoup de place et ça a impacté sur le retard accusé dans certaines mesures de prévention. Et nous avons constaté, par exemple, même pour la rubéole, la rougeole, nous avons repris certaines activités, en tout cas un certain nombre de mesures pour davantage rattraper le gap lié au fait que la COVID avait un peu pris beaucoup de place. Sinon, pour ce qui est de la polio, c'est la situation dans laquelle nous sommes. Et ce que vous dites, c'est tout à fait juste pour dire qu'il y a une sorte de lassitude de la population du fait qu'elle a été sollicitée. Mais notre devoir aussi, c'est davantage sensibiliser, davantage répéter, davantage passer le bon message. Et sur ce plan-là, nous comptons beaucoup sur les médias, notamment les médias de proximité. Donc voilà à peu près ce que je peux dire pour ce qui est du Togo. Pour dire qu'aujourd'hui, on a, pour le premier tour, vacciné 1 700 000 enfants.
Okay. If I may.
Yes.
Okay, thank you very much for that question. So if I can add, I think, of course, all of us, when we set out to eradicate polio, and especially when we celebrated the eradication of wild poliovirus type 1, because there are different types of poliovirus. So we need to make that clear as well, because there's a wild poliovirus and it was type 1, and that was eradicated from Africa. And there was justification in marking that milestone and celebrating that achievement. It's important as well so that people know that the cases that have been discovered of this type have been re-imported from somewhere else. So that eradication of wild poliovirus type 1 from Africa is still valid. The case that we are seeing has been linked genetically to a case in Pakistan, and the follow-up has shown that there has been travel connecting the first case that came to Malawi with Pakistan, and then subsequently, of course, that has spread to Mozambique because Malawi and Mozambique are neighboring countries and people move across those borders very actively. And then secondly, the minister was expressing his concern and actually making a plea that, it's confusing for people to hear about a vaccine-derived polio virus, which is actually not a wild type of polio virus, which is a type of virus that is able to attack children who are not vaccinated for the type 2 and which passes through the excreta mainly of children who get vaccinated. So it's not from being injected with a vaccine that this type of wild polio virus infects somebody. It infects children who are unvaccinated because a vaccinated child has excreted the vaccine into our systems of sanitation, and that there are problems with sanitation in many countries. That's how children then get contaminated with the second virus. He pleaded for us to find another name. And I think we understand that the communication may get confused if we say on the one hand, vaccinate your child, and on the other, it sounds as if you vaccinate or a vaccine can give a child polio. So we are looking now, having heard that and having thought about it before, I have to say, to expressing more clearly this phenomenon of a virus that is mainly attacking unvaccinated children. I think that's very important to emphasize because we have sanitation systems where other children who are vaccinated are able to leak the vaccine into the system. So we have a big job, and perhaps you can help us how to communicate this so people understand it's not the vaccine itself that's the danger, and they can be still coming to be to bring their children to be vaccinated. Thank you.
Thank you for emphasizing this, Dr. Moeti. Honorable Minister from Uganda, would you like to add on this?
Yes. First of all, I would like to appreciate the fact that the World Health Organization is emphasizing eradication of polio. And people need to be reminded that the process that the world went through to get rid of smallpox was not simple either. And that is the same process that we have to go through. Currently, we still have a lot of zero-dose children, that is children who are not vaccinated. We also have children that are under-vaccinated. And then unless all these children are vaccinated, we will continue to have these outbreaks that pop up from time to time that will take the world back in the race to end polio. It is therefore pertinent that together with the media, we communicate to the populations very correctly
l'évolution vers un double ou bien même triple fardeau de ces maladies aussi. À l'OMS, nous mettons l'accent d'abord sur la prévention, parce qu'il y a toujours la possibilité de prévenir ces maladies. C'est quoi? Il y a le diabète, les maladies cardiaques, l'hypertension, et nous savons qu'il y a quelques facteurs qui sont très importants pour ces maladies. D'abord, nous avons commencé l'autre jour, je ne sais pas si vous étiez là, avec la marche. D'abord, l'activité physique est très importante. Donc, ça veut dire que ce sont des habitudes que nous devons promouvoir dans la population et mettre sur place le dispositif pour que ça soit possible pour les gens. Donc, ce qui veut dire, ça demande une action multisectorielle. OK. Monsieur le ministre a déjà fait allusion aux multisectorialité de l'action.
Ministre, fait allusion.
La pandémie, je ne sais pas, est-ce qu'on peut faire quelque chose avec? OK. Donc, je vais essayer rapidement de dire
Merci beaucoup. Merci.
La réponse et la prévention de ces maladies demandent vraiment une action multisectorielle. Faire l'exercice. Il faut que les gens qui ne peuvent pas aller à la gym peuvent marcher quelque part et nous devons essayer de faciliter ça pour que ça soit sans danger, sans risque, et même pour les femmes, et promouvoir ça. L'éducation de la population est très importante. Deuxièmement, il faut éviter des effets néfastes de le tabac et de l'alcool. Là, il y a tout un groupe des activités. D'abord, les législations et des régulations au niveau des pays pour minimiser l'accessibilité à ces facteurs de risque, surtout pour les jeunes. Il faut des lois qui limitent l'accessibilité de l'alcool, qui fait que les enfants ne peuvent pas vendre, ne peuvent pas acheter de l'alcool, ne peuvent pas acheter des cigarettes, etc., etc. Et troisièmement, il y a des facteurs de la nourriture. Il y a la nourriture trop salée, trop gras, trop sucrée, un danger. Il y a tout un travail à faire avec le secteur privé qui profite de ça. C'est ceux qui vendent ce facteur de risque, enfin. Et il faut la régulation au niveau des gouvernements pour limiter l'accès à ça. Et surtout, il faut l'éducation des populations. Moi, quand mes enfants étaient petits, j'ai 2 filles, ils ont refusé à un moment donné de manger des choses parce qu'ils étaient dit à l'école, ça, c'est pas bon pour vous. Les boissons sucrées, là, ne sont pas bons pour vous. Non, ils demandaient l'eau et le jus. Et les enfants peuvent éduquer les familles aussi pour que nous soyons, comme on dit, sensibilisés sur ça. Et il y a tout un travail à faire là-dessus. Et enfin, le dépistage au niveau de nos hôpitaux, etc., pour savoir très tôt si quelqu'un a l'hypertension et le mettre sous traitement, parce que nos systèmes de santé ne sont pas encore assez capables de livrer le traitement pour tout ça. Donc, je crois qu'il y a la possibilité de minimiser cet impact. C'est bien d'avoir les prédictions, parce que ça nous encourage de prendre toutes ces actions-là qui parfois ne sont pas faciles, mais il faut le faire. Il faut que ça soit fait. Merci.
Merci beaucoup, Dr. Moeti, pour ces mots d'encouragement. Thank you very much for these wise words. Now we have a question from Health Policy Watch to Dr. Baraka. Dr. Baraka, what variant of the monkeypox virus is now spreading most rapidly in Africa? And isn't it the same one as that spreading globally through person to person, including sexual transmission, rather than zoonotic spillover events?
Thank you. So in Africa, we are experiencing transmission of monkeypox mostly in rural and peri-urban areas that's characterized by sporadic clusters that are mainly driven by person-to-person transmission among household contacts. Most of the cases that have been reported in 2022 have not been sequenced. However, the available sequences that we have indicate that the predominant variant is the clade 2B, which was formerly called the West African clade. And this clade 2B is the same variant that is currently circulating in other countries around the world. WHO is working with countries in the African region to try and scale up the sequencing of new and even historical cases where possible, so that we can better characterize the variant.
Thank you very much. Now we have a question to Dr. Atuhebwe. Dr. Atuhebwe, the COVID-19 vaccine is said to be the first, second, and booster. Now, after taking the booster, will you still need to take another round of 3 doses or any vaccine at all?
Thank you very much, and good day to you, our panelists, and the journalists. So if I understand the question, the person says that we have a first dose, then the second dose is a booster, and then the third is another booster. So this is not actually true. So we have had what we keep referring to as the primary series, which is for most vaccines, 2 doses, a first and second dose. And then after the first and second dose, 6 months later, we've been giving the booster dose. And then now we have a new guidance because the efficacy, that immunity that the booster dose is giving, or that the primary series are giving, keeps going away over time, what we are calling the waning of immunity. So after that is why we give people boosters. So what we know for now is that you need the primary series and then a booster dose 4 months after the first booster for the high-risk groups, for people who are at higher risk of getting a severe infection or being hospitalized and dying. You get a second booster 4 months after the first booster. Now, because the vaccine is new and hasn't been around for a long time, we are keeping on following the first people who got the first vaccines to see how long this immunity takes to decide, do we need extra boosters or not? However, the question was asking, do we need to repeat that series of vaccines that like we do for some vaccines? No. What we have will be called boosters, and we are yet to know, do we still need a third and fourth and fifth? Do we need a booster annually like we do for the flu vaccine or not? Again, the vaccine being new, we are still learning, and we shall be, WHO constantly does update the public and what is coming out of science to know if we need more boosters or not. Thank you very much.
Thank you very much. Thank you, Fiona, Dr. Atuhebwe. So last question that I will put to all 3 panelists. As we mark African Traditional Medicine Day on 31st of August, what concrete steps is WHO AFRO, is Togo, and Uganda doing to help develop this industry that caters for over 70% of health needs in sub-Saharan Africa? So over to Dr. Moeti first, and you can answer the question and deliver your final message at the same time.
Okay, thank you. Thank you very much. Indeed, the celebration of African Traditional Medicine Day is always an important occasion and milestone for us, because we are very aware that the traditional sector is a vital and important provider of healthcare to African communities and African populations. Over the years, what we have done as WHO is to really foster a collaboration between the traditional and the modern health sectors in countries, so that the framework, regulatory, defining the different roles, defining the interaction between the traditional and the modern sectors has been developed. And so that plans have also been developed in countries to see how to support the traditional sector, how to connect it effectively with the modern sector so as to have a synergistic impact on the health of people, because we know that many African people believe strongly in, and justifiably, because we see that the products that are used in traditional medicine have been developed in other regions, in other countries, and have had a very important impact on public health and on global health. So we have also supported trials on the efficacy and the safety of some traditional products. So we have some traditional products where we are able to say these are safe to use, they are effective for whatever is supposed to be the impact. And therefore the possibility exists then to have a market for them and to have people invest in their production so that they can be used. I believe that this is the phase that we are at now. And we've seen in some countries, like Benin, if you arrive at the airport in Cotonou, there's been some progress there in processing traditional products and in making them available in ways that are easily accessible. And I think that's the case in many other countries. And this, in our view, is an area that merits investment promotion once we have supported the kind of trials that provide evidence that this is something that works. There are also, of course, products that have not been taken through rigorous trials like that. And here, I think we need to continue to monitor how they are used in the same way as there are certain products in Western countries that are not called medicines that require to be prescribed as such. I think this is an area that deserves our additional concentration. And I'm very glad that in the region, we have resuscitated a very strong advisory group of experts who are involved in traditional medicine. And our dream really is to see effective African traditional medicine being commonly available the way we see Chinese traditional medicine being marketed all over the place in African countries. That's what we'd like to see, because we know that these products are available, people use them in our villages, they have faith in them. We need to take this to a different level, working with partners, of course, mobilizing investors in this so that we have our own industrial, safe, good African traditional medicine available in the way that we are buying them from China. That's what we'd like to see. Thank you.
Thank you, Dr. Moeti. This dream will materialize, inshallah. Ladies first, Uganda.
Thank you very much for that question. First of all, I must state here that the issue of African traditional medicine is very dear to the heart of my president, President Yoweri Kaguta Museveni, who is a strong advocate for African traditional medicine. And he has been championing this for many years past. And to show his strong support, Uganda has a law, the Traditional and Complementary Medicines Law, that came into play about 5 years ago, and has a board that follows up on all the new innovations. We also have a Department of Natural Chemotherapeutics, where a lot of research and development on African traditional medicines takes place. And I must thank WHO AFRO region for their support, because they've been sending a team of consultants to support us in this area. We've developed a standard protocol that is flexible and used by many new innovators that come up from time to time with the medicines that they have identified. And during this COVID pandemic, I must say there were many new innovations that came up. Some are still under study, some were studied, and we are yet to share results with the rest of the world. This issue has also been captured by our regulatory body, the National Drug Authority, that regulates both clinical trials and rollout of such African traditional and complementary medicines. There is, of course, now need to open up for more support for research and development so that we can expand on this area that is extremely useful, as the regional director has clearly stated. I thank you.
Thank you very much. Monsieur le ministre, pour le Togo, la médecine traditionnelle.
Merci, madame. Pour ce qui est de la médecine traditionnelle, quand on prend par exemple le ministère de la Santé, il y a ce que nous appelons la division de la médecine traditionnelle, à la tête de laquelle d'ailleurs se trouve le docteur Malou. Et donc, cette division existe depuis des années, compte tenu du fait que le gouvernement, il n'y a pas de doute, il n'y a pas de discussion, cette médecine a un apport important. Maintenant, quand vous prenez l'université de Lomé, à la faculté des sciences, il y a toute une série d'experts qui étudient les plantes. Et nous travaillons en collaboration avec ces experts-là. Alors, il a été question aussi d'organiser les acteurs de ce domaine-là, parce que dans ce domaine comme dans d'autres, il est utile d'organiser les uns et les autres pour que on distingue le vrai de l'ivraie. Alors, lorsque hier, on parlait des médicaments falsifiés de qualité inférieure, ça concerne aussi bien les médicaments classiques que ceux de la médecine traditionnelle. Donc, dans les deux cas, il y a à se pencher sur cette question et c'est ce qui fait que nous devons combattre la diffusion du faux à travers des communiqués ou à travers des véhicules qui circulent dans les quartiers et qui attribuent toutes les qualités à un produit qui n'a pas été l'objet d'études et qui n'est même pas souvent connu ou reconnu des acteurs de la médecine traditionnelle. Et ça, c'est une lutte que nous devons mener parce que actuellement, dans nos quartiers, vous voyez des véhicules circuler pour vanter les mérites de tel ou tel produit, qu'il soit classique ou traditionnel. Donc, dans les deux cas, il y a nécessité de procéder à cette correction. Bon, maintenant, ce qu'il faut aussi rappeler, c'est que contrairement à une opinion qui est très répandue, l'utilisation des plantes, la médecine que nous qualifions de traditionnelle, n'est pas une spécificité africaine. Quand on prend l'histoire de la médecine, il y a beaucoup de produits que nous utilisons dans la médecine classique qui viennent des plantes. L'aspirine, l'un des produits que nous utilisons le plus souvent, pendant longtemps, pendant des siècles, c'était extrait de deux plantes qu'on appelle le jus de peuplier et les feuilles de saule. Et c'est de ces plantes-là qu'on a extrait l'aspirine à la fin du 19e siècle. De la même façon, il y a un produit qu'on appelle colchicine. Pendant longtemps, c'est la plante qui lui a donné naissance, qui était utilisée dans le traitement de la goutte. Et c'était une plante qui était dans un village au bord de la mer Noire, un village qu'on appelle Colchis. C'est de là qu'est devenu le nom colchicine. Donc, il ne faut pas avoir une vision totalement rigide pour dire que ici, c'est les plantes, là, c'est les comprimés, et oublier qu'une bonne partie des comprimés ont une origine, viennent des plantes. Voilà. Merci beaucoup.
Merci, Monsieur le ministre. Nous avons été édifiés. Je vais à présent vous donner la parole à chacun pour un dernier mot, un message de fin. So, last word for this press conference, your final message. Maybe we start with our guests. Oui. Oui. Vous voulez commencer ou je donne la parole d'abord à Madame? Madame, Honorable Minister first, for a final message.
Thank you very much. Once again, allow me to appreciate the government of Togo for hosting us here for the 72nd Regional Committee for Africa, and WHO AFRO for a very well organized meeting where we have discussed very pertinent issues concerning Africa and also agenda items with interventions that have to be undertaken for us to see health in the African region improved, and also to see many of our countries move towards universal health coverage, which is our vehicle for resilient systems. Africa is able to handle many of these pandemics that keep on coming on board, and many of the disease components that are still bothering us. We only need to set health as a priority and ensure that nobody is left behind. Building resilient systems is possible, not only when we are focusing on pandemics, but focusing on infrastructure that is sustainable and human resources that are well motivated and trained to handle our health aspects. I am aware that resources are limited, but even within the limited resources, we can still do much more. There is need to continue to support WHO AFRO for them to support us in a better way. I will just say something small about non-communicable diseases. And again, we have to take note that WHO AFRO has been supporting countries to carry out STEP studies. Uganda is now in the process of carrying out the second STEP study. And the question that was raised by somebody, that 4 in every 10 is already a reality. It is not, we are not only moving there, it is already a reality that 4 out of every 10 persons has hypertension. But we are not looking at treatment, we must look at prevention. And everybody in Africa must emphasize prevention. Prevention not only for non-communicable diseases, but for all diseases in Africa. Because when we prevent, then we can use these resources to handle other areas. Once again, allow me to express our appreciation to WHO AFRO and to the government of Togo. I thank you.
Thank you, Honorable Minister. Professeur, vous avez la parole pour un message de fin avant que je ne donne la parole au Dr Moeti pour conclure. Oui.
Merci. Alors, merci à nos amis de la communication. Alors, tout à l'heure, il y a une de nos sœurs qui a parlé des maladies non transmissibles. Et c'est une importante question. Parce que pendant longtemps, on s'est dit, bon, ce qui tue le plus, c'est les maladies infectieuses. Les parasites, les microbes. Ce qui n'était pas faux. Bon. Grâce à l'hygiène, grâce aux vaccinations, nos populations, nous vivons de plus en plus longtemps. Si bien que les Européens, et ils ont réglé le problème schématiquement des maladies infectieuses. Et nous, on a à la fois les maladies infectieuses et puis les maladies non transmissibles. Alors tout à l'heure, il était question de faire de la prévention. Nous avons ici beaucoup d'entre nous qui ont plus de 40 ans. Les masculins, les hommes, chaque année, il faut faire l'antigène spécifique de la prostate. C'est un examen de sang parce que ça permet de détecter tôt le cancer de la prostate et qui est le cancer le plus fréquent chez l'homme de sexe masculin. On sait que ce cancer, il est plus fréquent chez les Noirs que chez les Blancs. Il est plus précoce chez les Noirs que chez les Blancs. Et c'est le cancer le plus familial, c'est-à-dire que si dans votre famille, il y a quelqu'un qui a un cancer de la prostate, la probabilité que vous ayez est beaucoup plus élevée que quelqu'un dont la famille en est totalement indemne. Donc ça, c'est le cancer de la prostate. Maintenant, quand on prend le cancer du foie, tout à l'heure, on parlait de l'alcool. L'une de ses causes, c'est l'alcool. Mais la deuxième cause, c'est les hépatites virales. Et il y a un vaccin contre au moins une des hépatites, l'hépatite virale B. Et donc, vous voyez qu'il y a des maladies qu'on qualifie de non transmissibles, mais qui peuvent avoir une origine transmissible. De la même façon, chez la femme, les deux cancers les plus fréquents, c'est le cancer du col de l'utérus et le cancer du sein. Alors, le cancer du col de l'utérus, il y a aujourd'hui un vaccin qu'on fait à la jeune fille adolescente. Et donc, c'est de dire que pour ce qui est évitable, ce qu'on peut prévenir, nous avons le devoir de le faire. Maintenant, pour le cancer du sein, il y a bien sûr l'autopalpation. Chaque matin, la femme cherche à savoir si sur sein, il n'y a pas une boule. Et puis, une fois par an, ou une fois tous les 2 ans, selon ce que le médecin lui a indiqué, elle fait un examen de radio qu'on appelle la mammographie. Ça permet de détecter précocement ce cancer-là. Alors, je profitais de l'occasion pour dire que nous allons en même temps faire un peu d'information et de l'éducation pour la santé pour ce qui est des maladies non transmissibles. Aujourd'hui, quand vous voyez comment il s'appelle, tous les plus de 40 ans au Togo, vous prenez les gens de plus de 40 ans, au moins le tiers sont hypertendus. Au moins le tiers sont hypertendus. La directrice régionale a parlé de l'alimentation, éviter le trop salé, le trop sucré, le trop gras et d'éviter d'être gros. Et puis faire de l'activité physique. Ça nous permet d'éviter l'hypertension, d'éviter le diabète et d'éviter aussi, puisque l'obésité favorise aussi les cancers. Donc voilà schématiquement le point que je voudrais ajouter par rapport à tout ce qui a été dit, pour dire que contrairement à ce qui était dit avant, on pensait qu'il y a des maladies qui sont réservées aux Européens, comme les cancers, comme les maladies mentales, comme les accidents vasculaires cérébraux, c'est fini. La répartition peut être différente, de même que les crises cardiaques, la répartition peut être différente, c'est vrai, mais ce n'est pas des maladies qui nous sont désormais étrangères. Donc, nous comptons sur vous pour nous aider à diffuser toutes ces informations-là et à contrecarrer la mauvaise information. Voilà ce que je voudrais ajouter. Merci beaucoup.
Okay, thank you. First, I'd like to very much thank my fellow panelists, Honorable Minister of Uganda, Honorable Minister of Togo, for having joined us in this discussion with our colleagues, the journalists. And again, our deep thanks to the government of Togo and the people of Togo, to His Excellency, the President, really for the excellent means that we are using for our conference. And then to conclude, I will not repeat what has been said by my 2 fellow panelists, but just to say, in the discussion during the last few days among the ministers, we've seen a lot of consistency in terms of emerging ideas and areas where we are to focus. Of course, we're dealing with a pandemic, and that has led us to talk about how to be more prepared and how to have resilience and how to have the connection between being able to respond quickly to an outbreak with the capacity to prevent through a strong health system. So it comes back really to investing in health systems that will deliver both for prevention, for access to treatment, and for resilience to outbreak, including early detection. That's come through very, very consistently. Secondly, that our main vehicle is going to be primary healthcare. We are very keen to make sure that not only do we have good hospitals in capital cities, but in the furthest village, there is a health center and there are some health workers who are motivated, who are knowledgeable, who will connect the people there, first of all, who will respond to many of their health needs and then connect them when it's necessary to the specialists, where we can have specialists only working on the most complicated diseases. That's second. And then thirdly, that science and innovation are really going to take us further. So that's something that we emphasize in Africa, because we need continued investments by our governments in our capacity for science, for innovation. We've seen in WHO that among our young technical experts and scientists, there is a huge capacity for innovation. It needs to be harnessed. It needs to be supported, because if you have innovators who have grown up in our context, in our countries, they know not only what needs to be done, but how it needs to be done in the best way so that it works. So for us, it's really that matter of innovation is important. Then finally, we've seen a strong emergence of the connection between the political leadership and the health sector in Africa. I think we've understood very clearly that a health problem like COVID has an impact not only on the health of the population, but also on the economy of the country and also on the security of a country. So if I can just make a last plea for some of the messaging that we would like you to spread is that health is important for economic development, not just for keeping people alive. And then finally, that we need our people, the communities, the families, to understand and to play their part and to be with us, to be with the presidents and the ministers in this work. I'd like to end by thanking you for the work that you do to spread information about health. And my final plea is that please spread information that persuades African people to come and be vaccinated against COVID-19. We have COVID-19 vaccines now. We have people like myself who have had 4 vaccines. I was only very mildly feverish after those vaccinations. And when I got COVID in Kenya a month ago, I was very mildly ill as a 68-year-old woman with hypertension because I had been vaccinated. So if I take myself as an example, please spread the word. Get vaccinated, especially if you are over a certain age, if you have a certain illness. And like me, you'll only get a slight cough, a runny nose for a day. And I continue to work through my COVID-19 illness. Thank you all very much for the work that you do.
Merci. Thank you very much, Dr. Moeti. Encore une fois, faisons-nous vacciner, get your vaccines. Ceci marque la fin de cette conférence de presse. Nous remercions les journalistes qui sont en ligne ainsi que ceux qui sont dans la salle. Thank you very much for joining us for this virtual press conference. Thank you to our journalists online, and see you next time for another press briefing. Thank you very much.
Yeah, you always say this shit's gonna change, but it never does.